What if the one thing you trusted to protect your heart, the very organ that sustains your life with every rhythmic beat, was secretly holding the potential for a catastrophic event, a hidden vulnerability that could erupt without warning? For over 70 million people worldwide, a tiny, often unassuming pill called amlodipine is a daily ritual, a familiar part of the morning routine, taken with a glass of water and a sense of security. It represents a shield against the relentless and silent assault of high blood pressure, a condition that, if left unchecked, can ravage the body's most delicate systems. This medication is a cornerstone of modern cardiovascular medicine, prescribed with confidence by physicians and relied upon by a vast population who believe it is their steadfast guardian. But what if that shield, which appears so solid and dependable, had invisible cracks? What if that little pill, sitting on your kitchen counter or nestled within your loved one's weekly medicine cabinet organizer, was doing far more than just keeping you safe from the dangers of hypertension? What if it was simultaneously and silently cultivating the conditions for a medical emergency of profound severity? In the coming moments, we are going to embark on a deep and unflinching journey, pulling back the heavy curtain on a side of this ubiquitous medication that few people ever hear about, a dark side that often remains in the shadows of medical literature and brief physician consultations until it manifests as a full-blown, life-threatening emergency. This is not about fear-mongering. It is about empowerment through knowledge, providing the critical understanding needed to recognize dangers that may be hiding in plain sight. You have likely been counseled by your doctor or pharmacist about the common, generally manageable side effects that can accompany the initiation of amlodipine therapy. These are the expected inconveniences, the trade-offs for better blood pressure control. You might have been told to anticipate a bit of dizziness, especially when standing up too quickly as your body adjusts to the medication's effects. Perhaps you were warned about the possibility of some swelling in your ankles or feet, a condition known as peripheral edema, which, while bothersome, is not typically considered dangerous. You might have even read the patient information leaflet, scanning the list of potential reactions and feeling confident that you know all the relevant risks. But what we are about to explore is fundamentally different. We are not discussing the mild and transient inconveniences that you can find on a standard patient leaflet, the ones that often resolve on their own or with a simple dose adjustment. We are peeling back the layers to expose the critical red alert warnings that your body could be screaming at you right now, signals that are too often misinterpreted or dismissed until it is far too late. One of these side effects, a terrifying cascade of systemic failure, is so severe that it sends thousands of unsuspecting users to the emergency room every single year, turning a routine prescription into a desperate fight for survival. This is not just information. This is a crucial and comprehensive guide to understanding the silent but serious dangers that could be lurking within a medication millions have come to trust implicitly. It is a call to vigilance, a plea to listen to your body, and a map to navigate a potential crisis. Imagine a perfect storm brewing silently inside your body, a malevolent synergy where 5 distinct and severe medical crises converge, each one feeding off the others in a terrifying, self-accelerating spiral towards complete systemic collapse. This is the harrowing reality of Brash syndrome, one of the most catastrophic and tragically under-recognized complications associated with amlodipine use, particularly when other factors are at play. The name itself, Brash, is not merely a descriptor of its aggressive nature. It is a clinical acronym that outlines the devastating chain reaction it triggers within the patient's physiology. Bradycardia, a dangerously slow heart rate that starves the body of oxygenated blood. Renal failure, the catastrophic shutdown of your kidneys, the body's essential filtration system. AV node blockade, a critical disruption of the heart's intricate electrical signaling, leading to profound cardiac dysfunction. Shock, a life-threatening drop in blood pressure that results in circulatory collapse. And hyperkalemia, the accumulation of dangerously high levels of potassium in your bloodstream, a condition that can be directly toxic to the heart muscle. The true insidious danger of Bresch syndrome lies not in any single component, but in the way these 5 elements create a vicious, self-perpetuating cycle of decline. It often begins with a subtle, almost imperceptible trigger, perhaps a mild case of dehydration from a summer heat wave, a bout of the flu, or the introduction of another medication weakens the kidney's ability to perform their primary function, filtering waste products from the blood. As their function falters, they struggle to excrete potassium, a crucial electrolyte that must be maintained in a very narrow range. As potassium levels begin to climb, they effectively poison the heart's delicate electrical conduction system, specifically targeting the atrioventricular AV node. This poisoning action slows the heart's rhythm, causing bradycardia. With a slower, less efficient heart, even less blood is pumped to the already struggling kidneys, worsening their function and, in turn, causing potassium levels to rise even further. This deadly feedback loop, where failing kidneys worsen the heart's function and a failing heart further damages the kidneys, can rapidly spiral out of control, leading to a state of profound shock and organ failure from which recovery is incredibly difficult. It is a medical nightmare where the body's own systems turn on each other in a cascade of destruction. The statistics associated with Bresch syndrome are profoundly sobering, painting a stark picture of its lethality and the long-term devastation it can leave in its wake. A comprehensive and detailed analysis of post-market surveillance data submitted to the U.S. Food and Drug Administration (FDA) revealed a chilling mortality rate. For every 100 patients who are diagnosed with this complex syndrome, nearly 6 will not survive the initial hospitalization. The battle for life is intense, and even for those who do survive, the road to recovery is often fraught with severe and lasting complications. A staggering 20% of patients, 1 in every 5, will require some form of renal replacement therapy, meaning they become dependent on dialysis machines to perform the basic, life-sustaining function of their now failed kidneys. This is a life-altering outcome, tethering patients to a demanding schedule of treatments for weeks, months, or in some cases permanently. The impact on the heart is equally alarming, with up to a third of all patients requiring the surgical implantation of a temporary and sometimes permanent pacemaker. This device is an external lifeline, a necessary intervention to artificially force their poisoned and failing heart to maintain a rhythm compatible with life. Case studies from medical journals paint a harrowing human picture behind these numbers, such as the widely cited case of an 89-year-old woman who was on a stable dose of amlodipine for years. She developed the full-blown, life-threatening syndrome simply because she became mildly dehydrated during a warm spell. Her story serves as a stark and powerful reminder that for vulnerable populations, particularly the elderly or anyone who develops a concurrent infection or illness, this hidden risk associated with a common blood pressure pill can rapidly escalate from a theoretical possibility into a desperate life-or-death reality. It underscores the critical importance of recognizing that even minor changes in health, like dehydration or a simple stomach bug, can act as the spark that ignites this catastrophic internal firestorm in susceptible individuals. Beyond the hidden internal warfare that can cripple the heart and kidneys, amlodipine can stage a much more visible, chronic, and distressing takeover of your oral health through a condition known as drug-induced gingival hyperplasia. In layman's terms, this means that the soft, delicate gum tissue surrounding your teeth begins to grow excessively and uncontrollably, often creating firm, pale, and nodular enlargements that can slowly and relentlessly envelop the crowns of your teeth. This is not merely a cosmetic issue that affects the appearance of one's smile. It is a serious functional and psychological problem that can profoundly and negatively impact a person's quality of life in numerous ways. While the reported incidence, affecting between 1.7% and 3.3% of users, may seem like a relatively small number on the surface, the sheer ubiquity of amlodipine prescriptions means this translates to tens, if not hundreds, of thousands of people struggling with significant and progressive oral dysfunction directly caused by their medication. What is particularly concerning and shatters a long-held medical belief is that this abnormal tissue overgrowth can begin within just 6 months of starting treatment, and it has been documented even at the lowest standard dose of 5 milligrams daily. This finding debunks the outdated assumption that only high doses or long-term use posed a significant risk, revealing that vulnerability to this side effect can be present from the very beginning of therapy for certain individuals. The condition typically manifests as a painless, gradual swelling, starting at the papillae, the small triangular pieces of gum between the teeth, and slowly spreading until the gums appear bulky and overgrown, altering facial contours and making simple acts like smiling a source of self-consciousness and anxiety. A groundbreaking study published in 2024, which meticulously analyzed patient data, uncovered a surprising and statistically significant detail that adds another layer of complexity to this condition. Men are 3.3 times more likely than women to develop amlodipine-induced gingival hyperplasia. The precise reason for this dramatic gender disparity is still under investigation, but it points towards a potential interplay between the drug's mechanism and hormonal factors. The enlarged gum tissue, which typically makes its first noticeable appearance within the first 3 months of therapy, creates a host of secondary problems. It makes maintaining proper oral hygiene incredibly difficult, if not impossible. The overgrown tissue forms deep pseudo-pockets around the teeth, which are perfect breeding grounds for bacteria, leading to chronic inflammation, bad breath, halitosis, and a significantly increased risk for periodontitis, a serious gum infection that can destroy the bone supporting the teeth. As the condition progresses, it can physically interfere with chewing, turning meals into a difficult and painful ordeal. It can also impact speech, causing a lisp or difficulty with clear articulation. Perhaps the most troubling aspect of this condition is the potential for permanence, a lasting legacy of the drug's effect. Compelling research shows that even after a patient stops taking amlodipine, the overgrown gum tissue may not fully recede on its own. For many, the only effective solution is a surgical procedure known as a gingivectomy, where a periodontist must physically cut away the excess tissue with a scalpel or a laser. This suggests that the drug may trigger lasting, perhaps irreversible, fibrotic changes to the very cellular structure of the gums, a permanent reminder of the medication's unintended consequences. There exists a deep and profound irony in the fact that a medication so frequently prescribed with the intention of protecting the delicate microvasculature of the kidneys by lowering systemic blood pressure can, under specific and critical circumstances, become their worst and most immediate enemy. While amlodipine is generally considered to be safe for the kidneys when taken at normal prescribed doses, the situation changes dramatically in the context of an overdose or when it is combined with other medications that also place stress on the kidneys. In these scenarios, it can trigger a devastating condition known as acute kidney injury, or AKI. This is not a gradual decline in function, it is a sudden and catastrophic event where your kidneys, the body's essential and tireless filtration system, abruptly and completely stop working. When this shutdown occurs, toxic waste products such as urea and creatinine, which should be efficiently filtered from the blood and flushed out of the body in urine, instead begin to accumulate rapidly in the bloodstream. This buildup, known as uremia, effectively poisons the body from the inside out, disrupting the function of every other organ system and creating a rapidly escalating medical emergency that requires immediate and aggressive intervention to prevent death. The risk is not theoretical. It is a documented and dangerous reality of amlodipine toxicity. The underlying mechanism of this nephrotoxicity is tied directly and inextricably to the drug's primary pharmacological function, vasodilation, or the relaxation and widening of blood vessels. In a therapeutic dose, this effect is beneficial, lowering blood pressure to a healthy level. However, in an overdose, amlodipine causes such a profound and uncontrolled vasodilation that it leads to a severe and precipitous drop in blood pressure, a state known as refractory hypertension. This effectively starves the kidneys of the adequate blood flow and pressure they require to operate. Think of the kidney's filtering units, the glomeruli, as a sophisticated water filtration system that requires a certain amount of water pressure to push the fluid through the filter media. Without that essential pressure, the entire system grinds to a halt. This state of severe renal hypoperfusion leads to a condition called oliguria, where urine production plummets to dangerously low levels, or even anuria, the complete cessation of urine production. Instead of producing over a liter of clear urine per day, the body might only produce a few milliliters of dark, concentrated fluid, a clear and ominous signal of severe kidney distress. Patients who experience this catastrophic event require emergency admission to an intensive care unit. They are often treated with potent vasopressor drugs to artificially raise their blood pressure and may require emergency hemodialysis, a procedure where their blood is externally pumped through a machine to be cleaned, taking over the job of their failed kidneys. This life-sustaining treatment may be needed for weeks or even months, and for some, the damage is so severe that they suffer a permanent loss of kidney function, condemning them to a lifetime of chronic kidney disease and dependence on dialysis. Stevens-Johnson syndrome, often abbreviated as SJS, stands as one of the most severe, visually horrific, and emotionally devastating adverse drug reactions known to medicine. It is a true dermatological emergency, a condition where the body's own immune system launches an all-out war against its skin and mucous membranes. While it is classified as a rare event, with an estimated incidence of around 7 cases for every 1 million amlodipine prescriptions, the sheer number of people taking the drug means that hundreds of individuals may face this terrifying ordeal each year. Its effects are nothing short of catastrophic. SJS is an extreme T-cell-mediated hypersensitivity reaction that causes the epidermis, the outermost layer of the skin, to blister, die, and peel away from the underlying dermis in large sheets. The condition often begins deceptively, masquerading as a common viral illness with non-specific flu-like symptoms such as a high fever, a sore throat, body aches, and a general feeling of profound malaise. Within days, however, the true and terrifying nature of the condition brutally reveals itself. A painful, red or purplish rash erupts, typically on the face and trunk, which then spreads rapidly. This rash is not like a typical allergic rash. It is intensely painful to the touch. The red patches quickly evolve into fluid-filled blisters, or bullae, which then merge and cause vast sheets of skin to detach from the body, leaving behind raw, weeping surfaces that are exquisitely painful and highly susceptible to infection, creating an appearance similar to that of a victim of a severe, full-body burn. This terrifying reaction is not limited to the skin that you can see on the outside. It also viciously attacks the mucous membranes that line the body's orifices and internal passageways. The mucosal surfaces of the mouth, eyes, nose, genitals, and even the respiratory and gastrointestinal tracts become inflamed, blistered, and ulcerated. The pain is described by survivors as excruciating and unrelenting. The consequences are dire and life-altering. The mortality rate for Stevens-Johnson syndrome is estimated to be up to 10%, but for its even more severe form, known as toxic epidermal necrolysis or TEN, diagnosed when more than 30% of the body's surface area is affected, the mortality rate can soar as high as 50%. Death, when it occurs, is often the result of overwhelming complications such as sepsis from widespread bacterial infection of the denuded skin, severe dehydration and electrolyte imbalance from massive fluid loss, pneumonia from sloughing of the bronchial lining, and ultimately, multiple organ failure. The condition progresses with terrifying and unpredictable speed, often reaching its peak severity within 24 to 48 hours of the first skin lesions appearing. Immediate withdrawal of the suspected offending drug and hospitalization, preferably in a specialized burn unit or intensive care unit, are absolutely critical for survival. Patients require meticulous wound care, aggressive fluid and electrolyte replacement, powerful pain management, and nutritional support, often through a feeding tube, as they fight for their lives against their own immune system's catastrophic betrayal. Deep within the complex and flowing river of your bloodstream are millions of tiny disc-shaped and absolutely vital cellular fragments called platelets. or thrombocytes. These microscopic elements act as your body's first responders to any form of injury, the vigilant sentinels that rush to the site of a cut or internal damage, clumping together to form a clot and staunch bleeding. Amlodipine, in rare but well-documented cases, can trigger a serious and potentially fatal autoimmune condition called drug-induced immune thrombocytopenia, a scenario where your body's own sophisticated immune system wages a devastating war on these essential cells. Through a frightening mechanism of molecular mimicry or friendly fire, the immune system mistakenly identifies the body's own platelets, particularly when they have the amlodipine molecule bound to them, as a foreign and dangerous threat that must be eliminated. Specialized antibodies are produced that tag these platelets for destruction, marking them for removal by macrophages in the spleen and liver. As a result of this relentless and systematic attack, your platelet count can plummet from a normal healthy level of 150,000 to 450,000 platelets per microliter of blood down to a critically and life-threateningly low level, sometimes falling to just a few thousand. Without a sufficient number of platelets, your body loses its fundamental ability to protect itself from bleeding, both externally and internally. The symptoms that arise from this condition can be sudden and alarming. A person might develop large, dark, and unsightly bruises, ecchymoses, from the slightest, most insignificant bump. They may experience persistent and frightening nosebleeds, epistaxis, or find that a small cut from shaving refuses to stop bleeding for hours. A hallmark sign is the appearance of petechiae, a rash of tiny red or purple spots on the skin, particularly on the lower legs, which are actually miniature hemorrhages from tiny broken capillaries under the skin. The most feared complication is spontaneous internal bleeding, particularly an intracranial hemorrhage, or a bleed inside the skull, which can be fatal. A major challenge in managing this condition is amlodipine's very long half-life, which ranges from 30 to 50 hours. This means that the drug lingers in the body for many days after the last dose is taken, continuing to fuel the immune system's destructive assault on the platelets. Recovery is therefore a prolonged and precarious process, requiring immediate discontinuation of the drug, often platelet transfusions, to temporarily boost the count, and the administration of powerful medications like corticosteroids or intravenous immunoglobulin, IVIG, to suppress the overactive and misguided immune response. Angioedema represents a sudden, rapid, and potentially deadly type of allergic reaction that causes massive, disfiguring swelling deep beneath the surface of the skin. Unlike a simple hives or a rash which affects the superficial layers, this swelling occurs in the deeper subcutaneous and submucosal tissues, leading to a dramatic, tense, and puffy appearance, most commonly affecting the face. The lips can swell to several times their normal size, the eyelids can swell shut, and the tongue can become so large it fills the entire oral cavity. While initial clinical trials for amlodipine suggested a very low incidence of this adverse effect, more recent and extensive post-market safety monitoring indicates that the true rate may be higher than previously thought, and its sheer unpredictability makes it an especially dangerous potential side effect. The swelling can develop with shocking speed, sometimes within minutes to hours of taking a dose of the drug, but it can also have a delayed onset, appearing weeks or even months into a treatment course that was previously well tolerated. This delayed reaction is particularly insidious, as it can catch patients completely off guard, having lulled them into a false sense of security with their long-term medication. The true, life-threatening danger of angioedema is its terrifying potential to cause acute and complete airway obstruction. When the swelling preferentially targets the tongue, the pharynx, the back of the throat, and the larynx, the voice box, it can rapidly and progressively close off the throat, blocking the ability to breathe. This is a code red medical emergency, a situation where every second counts. The patient may first notice a feeling of tightness in their throat, followed by difficulty swallowing, a change in their voice to a hoarse or muffled quality, and then the terrifying sensation of stridor, a high-pitched whistling sound made while trying to inhale through a narrowed airway. This is the final warning sign before complete asphyxiation. Such an The event requires immediate emergency medical intervention, including the administration of high-dose corticosteroids and epinephrine to try and reduce the swelling. In severe cases where the airway is closing, paramedics or emergency room physicians may need to perform an emergency endotracheal intubation, or if that is impossible due to the extent of the swelling, a cricothyrotomy, a surgical procedure to make an incision in the neck and insert a breathing tube directly into the trachea. It is a terrifying and traumatic experience that underscores the absolute importance of recognizing any sudden facial, lip, or tongue swelling not as a minor allergic reaction, but as a serious and urgent warning sign that demands immediate medical attention to prevent a fatal outcome. Thank you for taking the time to learn about these critical risks. If you found this information valuable, please consider sharing it to help raise awareness.